for joining us. I'm really excited for our 5th webinar in the Telehealth Initiative program. And today we are going to focus on addressing the digital divide. And this was something that has come up in previous webinars during our polling and just Q&A around some of the challenges and barriers that still exist to telehealth. So really excited today to have some guests with us. So you'll get to hear a little bit about the AMA Center for Health Equity, as well as some of the work that colleagues are doing at the University of California, San Francisco. So both will be kind of focused on health equity, the innovation space, and really kind of bridging those challenges around access to tech, digital literacy, and topics like that. So again, really excited for our guests this evening, and thank you very much for being here. And there will be plenty of time for questions and answers at the end. Quick overview of our CME information. This is available for CME if you are joining us live. You are eligible for 1 AMA PRA Category 1 credit through Massachusetts Medical Society. None of our speakers this evening have any relevant disclosures. And the CME objective for today is really to be able to assess the efficacy of the practice's telehealth implementation and service, and take these steps to close some of the gaps that have been identified, especially focused on this area that has been identified by the group as kind of still those challenges that everyone is seeing in their practices. So I'm excited to introduce you to Chelsea Hansen. She is the Director of Health Equity and Innovation at the AMA, and she's going to share a little bit more about our Center for Health Equity, as well as the strategy around addressing health equity related to innovation and technology.
Great. Thanks so much, Stacey. Hopefully everyone can hear me okay. Thanks so much for having me. I will do my best to represent the Center for Health Equity and share a little bit about the work we're doing at the AMA to advance equity in the healthcare space. So I am not a physician, I'll just start with that. So all of your physician-related questions will go to our guest speakers tonight, and anything about sort of the on-the-ground work and the important work that Dr. Lyles and Dr. Sarkar are doing. So I don't want to give anything away, but my background is actually in the health innovation space as both part of the startup community as an entrepreneur myself, in my past life, and working with other startups in the digital health space. And then also working on equity and tech and prior to that. So bringing that perspective into my work within the center. I've been with the AMA for about 4 years. The Center for Health Equity was actually formed a little over a year ago to really advance the work that we as the AMA not only are doing to advance health equity broadly, but also to transform our own organization, which for 170 years, has been on our own journey, and we have a lot of work to do internally as well. So the Center for Health Equity vision and mission is on the slide, and I won't read this to you, but really, as I mentioned, there's a lot of work to do around addressing disparities in health outcomes by race, gender, sexual orientation, gender identity, age, other identities where we do see significant differences in outcomes. And really not only just sort of looking at those outcomes as they stand, but also what's behind them. We'll talk a little bit more about the sort of historical and contemporary injustices and discrimination that are important for us to think about. If we go to the next slide. So, this is one, I think, great visual of what we mean by health equity within the AMA Center. And so again, there's sort of uses of the word equality and equity, I think, can often be, used interchangeably, but really it's about, in our minds, sort of getting to that state at the end, at the far right of liberation, right? So that's breaking down barriers, not just sort of assuming that everyone is on this, getting them on the same footing with the same access to resources, but in some cases, providing resources that may look like they're going above and beyond for groups that have been facing, again, what you can see in that reality photo, very different starting points. So again, for us, health equity means having the conditions, resources, opportunities, and power to achieve optimal health, regardless of identity. And the next slide. So I mentioned this a little bit in my opening comment about our vision and mission, but really when we think about health inequities, it's important to take sort of what we call an upstream approach. And we did not invent that term. So this is one of many organizations that uses this sort of approach and model. And so you can sort of see downstream, right? Which again, I won't pretend like I know what it's like to be a physician. I'll let others talk more from their own direct experience. But I think what's often seen in practice are the outcomes, right? So the downstream sort of impacts, behaviors, disease and injury, and of course, ultimately mortality, right? But when we look upstream, we see things that vary based on some of those identities I mentioned, right? So living conditions, so access to safe places for exercise, the economic and work and sort of income opportunities that are available. I know especially with the current environment we're in, we've talked a lot about policing and safety, and how that's sort of impacting certain communities like our Black communities differently. And that really, again, is sort of framed in institutional and social inequities that have been around since, again, the sort of invention of race as a social construct. So there's a lot there. And again, we're not saying that it's our job to solve everything within healthcare, but I think to be very aware when we talk about some of the behaviors and the disease, and injuries or presentations that we're thinking about what's sort of happening upstream. Next slide. So within the Center for Health Equity, we have 5 strategic approaches. And as I mentioned, starting on the left very quickly, creating pathways for healing, truth and reconciliation are really important. We recognize that we've been on the wrong side of this for many years as an organization, and that we have not always taken equity as a priority in the way we've developed our policy and supported legislation. And we have a lot of work to do ourselves. And I won't belabor that on this call, but certainly happy to chat more about what we're doing there. It's also critical, if we sort of flow around here, that we embed equity into everything that we're doing. It's not just the center's job. We see it as our opportunity to sort of support all of our 1,100 or so colleagues in bringing an equity lens to their work that they're doing. Building alliances and sharing power is really important, right? We know, again, that we're kind of coming in a little bit new to this space in the sort of historical frame here, and that there are many that just have done incredible work for a very long time, especially those from those marginalized communities. And we need to sort of approach this with that mindset of how we can sort of leverage the power and privilege we have to advance this work. Pushing upstream, as I mentioned before, I'm going to skip over the one I've circled for a second here. The pushing upstream is, again, really thinking about how we can support physicians and understanding sort of public health, really the sort of frameworks of public health. And I think we've got folks that are MD, PHs that already know this well, but a lot of our physicians aren't really trained to think about upstream causes. So, I think that's a big focus for us as we think about educational opportunities. No worries, I have the slides on my end too, Stace, so just let me know.
I'm so sorry,
No worries. This happened to me yesterday in a similar environment, so this is, I guess, payback. And the last one is ensuring equity and innovation. And so as we think about telehealth and telemedicine, it's the equity and innovation sort of strategy that really emphasizes this work that's relevant to today's conversation. And that's ensuring that there are equitable opportunities and conditions in the innovation, so in sort of areas like telemedicine for marginalized people and communities. And that includes those developing solutions, but more than anything, those that are sort of designing, those who our solutions are being designed for. So equity and innovation, our vision is laid out here, right? So that means within the healthcare innovation sector that, investments in things like telehealth and telemedicine, digital health solutions, that we're seeing more investment and resource allocation to solutions that are advancing health equity, so health, racial, and social justice, and that other solutions that maybe aren't intentionally focused on that they're at least applying an equity lens so that we're not exacerbating inequities with this innovation. The other piece is we need to see more diversity and representation in those that are sort of in the positions of power around making decisions on which solutions get investment, right? And so I know there's been a lot of talk recently about, again, the fact that, there's 1% of all venture capitalists are Black and 1% are Latinx, and that's a problem. We know our population is about 30% of the two. And so how do we sort of support and encourage greater representation in those that are designing and developing solutions, so that that's sort of top of mind. So I won't go through all of this, but again, there's a lot of work the AMA is embarking on doing as it relates to equity and innovation broadly. And again, a lot of it is sort of equipping, engaging, collaborating, amplifying the work of others in this space, and recognizing again that we have an opportunity to be part of the solution, but we certainly cannot do all of it on our own, and nor should we do all of it on our own. The next slide. So that brings me to health tech and specifically telehealth. And again, I will just very quickly talk about sort of what we're thinking in this space and then let our guests share more. So I think that, there's been a lot of great conversation and a lot of great progress in telehealth and access to telehealth, in the days of COVID and the times of COVID. But what we're seeing with telehealth inclusive, and other health tech solutions, patient portals, mobile health, is that we're not, the access that's sort of increasing is not equitable, right? We know that there are populations of color in particular, and low-income populations that are being left behind. And so these benefits and the development and advancement in these solutions and advancement in access are not reaching all populations equally. Next slide. So there's sort of 5 drivers here, and I know this slide's a bit heavy. I think there's one more click. I'll just let you get to it there. So when we talk about, why those inequities exist, why the access isn't equal and why, or equitable, and why, the experience might not be equitable, we hear things like access to the devices themselves, right? So if you don't have a smartphone or a computer that you can use to sort of access telehealth, that's an issue, right? Connectivity is an issue. We talk a lot about broadband, relevance of the design. So is it in the language that works for me, or do I see myself when I engage in this product? Do I feel like it was designed with me in mind? And then digital literacy is something we talk about on the patient side. Like, are these patients from these marginalized communities able to engage and sort of use this technology? I mean, all of that is sort of baked into the healthcare system as well, right? So there's sort of the patient side of this and sort of the lack of equitable access to what's needed to make this effective and sort of the factors that impact patients. But then we have to think about the delivery system, the care delivery system in which they're receiving care. And so we know that those who are receiving care in FQHCs and community health centers, the physicians and the care teams that are treating them also have lower resources, may not have access to video visits and other technology solutions that more resource-rich settings may have. And so I think all of that taken into context, and then you sort of, again, take that upstream approach and say, well, why do these drivers exist, right? What's behind device access? What's behind connectivity and design relevance? And that's sort of where you go deep, right? And there's a lot to this. And again, I'm not suggesting that all of us on this call are meant to sort of solve all of these issues, but I think it's important that we think about things like, income disparities and lack of sort of focus on equitable access to broadband, and educational system issues, right? And I think the design one is really interesting, and that sort of links back to one of our goals, as I mentioned, at Center for Health Equity. And that's, if you have 90% of venture-backed companies led by straight white males, I mean, you're going to have, again, a lot of solutions that are designed for that population. And there's nothing wrong with straight white males. I'm not saying that. What I'm saying is when you don't have representation in sort of those who are designing in these settings, you're going to find that the solutions themselves are not reflective, right? And so I think there's sort of that systemic issue there. And again, that's not the only thing, but I did want to make that as an example of sort of why that's part of our strategy. So I think there is maybe 1 or 2 more slides. I won't read the next slide in detail, but what can we do as we think about sort of the roles we all play, and whether that's helping design solutions or selecting and adopting them in our practices. So what are some of the questions that we can ask as we think about sort of assessing these and sort of the equity lens that's either present or missing in the design of these solutions? And then I think finally, there's a slide with some more resources. So again, a link to our website. We're still working on, again, as a newer center, working on building that out. I don't want to give away the resources for telehealth and safety net settings that I'm sure Dr. Sarkar and Lyles will talk about, but some other interesting information here that hopefully will be helpful and new, and definitely welcome other ideas as well. So with that, speeding through that, hopefully not too horribly, I'm going to introduce our guest speakers again, who are experts sort of on the ground and from a research perspective in this area that I am, privileged to sort of be able to, watch and engage and hopefully collaborate and amplify. So Dr. Amimala Sarkar and Dr. Courtney Lyles have many roles, but they are the co-founders of UCSF SelfTech, which they founded in 2016. They both have research and experience caring for patients in the medical safety net, where they've learned a lot about, again, those health inequities that we've talked about, and specifically related to digital health tech and user needs. So SelfTech's mission is to bridge expertise on diverse patients with companies that are developing digital health technology to create and adapt products that truly reach all populations. So they're doing the work to address some of the strategies and opportunities that I've described. Dr. Sarkar is a professor of medicine at UCSF, the associate director of the UCSF Center for Vulnerable Populations, and a primary care physician at Zuckerberg San Francisco General Hospital's Richard H. Fine People's Clinic. I'll let her talk more about her extensive experience in evaluation of technology interventions in real world settings and her passions in this space. Dr. Lyles is an associate professor of medicine at UCSF, also based at Zuckerberg San Francisco General Hospital. And she's a trained health services researcher, uses quantitative and qualitative methods to understand quality of care, health behavior, and health outcomes. Lots of really interesting work that these two have done together and with others, and I will turn it over to them to share more from their experience. So thank you both for joining us and for having me.
Thank you so much. Thank you, Stacy, and thank you for the introduction, Chelsea. That was so nice of you. So yeah, I was going to get it started for us today, and then Urmimala is obviously going to chime in. So we're going to sort of tag team some slides about some of our work. Go to the next slide. These are our disclosures, not going to talk about any of those today. So Chelsea already introduced us, and I think we both do academic work, like she mentioned, and we started SelfTech, and I think it's relevant for telehealth. So just to sort of emphasize that again, we work a lot in academia, trying to understand why, especially lower income and diverse patients, and how they interact with health interventions, and particularly digital interventions. But we're not going to be able to solve the problems unless we can partner with the private sector in a new way, in my opinion, to make sure that they're also developing products and solutions. And so Chelsea, you set that up perfectly. So why we do our academic work and why we're trying to start something like Solve to sort of partner in a different way. So that's who we are. In terms of the agenda, you can go to the next slide now. Thank you. Oh, perfect. So I thought I would set some background for today about about sort of the digital divide and what you might not know, and maybe what has become more apparent with the pandemic in particular, and also give a little bit of research about patient portals and how we've thought about those, which I think does relate to what we're seeing in telemedicine. And then Urmimala will go into some more of the recommendations and what we've been doing at our delivery system that might be relevant for trying to think about addressing some of the disparities in telemedicine. So to get it started, I mean, these are some of the numbers when we think about it. I think a lot of the discussion prior to the pandemic was really that the digital divide is shrinking and that everybody owns a smartphone. And for a lot of populations, that is true, but particularly for older adults in the United States, for low-income adults, and for those in rural areas, there are some significant barriers, including the stats on this slide, in terms of, I call it the 3 pillars of trying to do digital health interventions. So that would be a device, high speed or high quality data or internet, and then of course the skills to be able to do things online. And the only other thing that's interesting about these stats is that actually there's a really growing stat that low-income individuals are actually increasingly becoming reliant on their smartphone for their data plan. So about a quarter of low-income adults in the United States actually have no home broadband, most likely due to cost, and rely completely on the data plan from their phone to access the internet. And that's been going on for a while, and I think the pandemic has really emphasized that, probably in more other sectors like education and the inability for some students to even participate in distance learning. But I think we need to bring that conversation into the health domain as well, given that the same kind of barriers will happen for video visits, for other app push out and interventions that we might deliver, particularly telehealth, of which we really want to do video visits, not just only telephone visits. We really want to figure out across systems how to do both video and telephone based on what patients prefer and want. You can go to the next slide. In terms of, I thought I'd give one more concrete example of what that looks like. So Urmimala and I are based in San Francisco. It's largely thought of as a tech mecca, you know, right, in terms of the world. And we are grateful and very lucky in San Francisco to have a San Francisco digital equity initiative that sits in our mayor's office. And so they recently, last year, put out a survey of some of these 3 things that I just mentioned, so devices and home internet and literacy skills among San Franciscans. And you can see here that the dark blue and that purple together are internet users, so people who have internet at home. And overall in San Francisco, it's probably what you would expect nationwide. Well over 90% of San Franciscans are using the internet. But that literacy bar is what's really interesting. And as you go into some subgroups, even in San Francisco, you can see some really big differences, especially those that both have the internet at home and say they can do basic digital literacy things. And these are things like searching for something online and sending an email. That there's some pretty big gaps, especially among non-English speaking populations in San Francisco, the oldest adults, and then the lowest income, those making less than 25,000. Oh, there's a little typo there, less than 25,000 a year. So pretty big, a pretty far way to go, even in San Francisco, a pretty connected, I would say, city. So on the next slide, so this already related to some disparities in telehealth. So before COVID, people like Rock Health, an incubator for digital health companies, had done a lot of national surveys about what people were doing with digital health devices and services. And telemedicine had some pretty large variation across different samples in the United States about what experience people were having with telemedicine. It's not surprising. So they had a vulnerable group in their survey defined as Medicaid patients or patients who are low income. And you can see here much lower rates of that group, and also chronically ill seniors having ever tried telemedicine, a live video visit with their doctor, compared to other groups like they defined as worried well, so younger, healthier kind of populations. And so that's really the emphasis here. This existed before the pandemic, but you can see here, the one other line on here that's interesting is the searching for health information line is not different across these groups. Like, everyone is really interested in using health tools online across all of these sort of subgroups, but real differences in the types of tools, telemedicine, and also some of these others like wearables and other things. Go to the next slide. And then the last thing I wanted to underscore is we really weren't doing a ton of telemedicine before this nation. Kaiser and other places, we're definitely doing a lot of telemedicine, but I wouldn't say at scale live video visits were, there wasn't a huge body of literature about these prior to the pandemic. And so I think we can lean on some other evidence that might help us think through strategies for transitioning and potentially what we might be as patient portal evidence. So similar to that previous slide, there's been lots of really research showing the high interest among patients in patient portal functionality. So
is that Caden, number 2?
Communicate with their doctor, high interest in
He's warmed
being
up.
able to receive their test results online, things like that.
Where do you guys get
But what we learned from the barriers about patient portal research is really, I think, going to play out for telemedicine. So people express when they don't want to use patient portals or haven't used a patient portal that they really prefer in-person modalities of care versus digital modalities. And even in the pandemic, that's going to be true, and it's going to probably persist even when we go back to more quote unquote normal care modalities, is that we want to deliver more virtual and more asynchronous and lots of variety of telemedicine visits to our patients, I think, to meet them where they live and to do a better job meeting their preferences. But we have to make sure it's paired with some sort of human support, in my opinion, to make sure that continuity, the relationship, all the things about having a relationship with your doctor, we can't forget about that. There's been some lack of perceived need, which I actually think is potentially, if there's any silver lining in the pandemic, people are more likely to try telemedicine now than they might have tried a year ago. Older populations, lots of populations who might need more help and support doing it still might be more motivated to try something out now. And so we have to think about how people are thinking about that. But we cannot forget about technical support that comes up over and over in the patient portal literature. People really want to know that somebody could help them troubleshoot or answer questions about how to use things and have somebody to rely on. And Urmimala will talk about that in her slides. And then lastly, there's obviously communication barriers. With patient portals, of course, we have a problem of only usually putting them out in English and having a lot of jargon on them, which isn't as relevant for a video visit, but I think communication barriers for video visits really relate to making sure medical interpretation and other things are available so that people can really access the type of care that they need and get the information that they need to be able to make decisions and manage their condition. So hopefully some of those are relevant. There's some slides, some citations here in case you're interested in portal studies that might be relevant for the telemedicine transition. And next slide. I think that's all I had. Yeah, so now I'm going to turn it over to Urmimala and talk a little bit more on the ground, like what can we do? Given that context, what can we do now?
Hi, can you guys hear me? Okay, great. What I want to do in this second part of the talk is to hone in really on what we're doing when we're doing telehealth visits and how can we make them more equitable. So this slide is just a placeholder for me to remind you that in the few studies that have already come out about telehealth equity during the pandemic, we're not doing that well, and there are real barriers for patients with limited English proficiency and limited health literacy to be able to access telemedicine. And this is something that has been particularly fraught in the safety net, where we disproportionately see low-income patients and publicly insured patients. One thing that I also want to keep in mind as we talk today is, as much as we're talking about infrastructure on the patient side and how whether patients have smartphones, whether they have internet access on an actual computer, there are also real infrastructure barriers on the provider side, in that Courtney and I were having a telemedicine discussion this morning with our colleagues at another safety net hospital in Northern California. And one of the ambulatory CMO who we were talking to said, "I'm so sorry you can't see me because I have no webcam at my work computer." Right? And this is really common. People who work in FQHCs often do not have either sufficient broadband access to conduct multiple video calls in the same space, or equipment, right? And so that's something we also need to attend to as we think about equity. Okay, so broadly, our overall strategy to think about identifying disparities is to do a couple of things, right? So there are some digital equity intake questions, and I've put the link to those questions. It's a Google Drive that anyone can access if you want to have a series of questions that will hopefully help you gauge where your patients are. And then sometimes a medical record review through the EHR can also provide some insight into people's electronic access. And then that understanding of where people are is really an important starting point and benchmark to then developing a strategy for telehealth equity. And then I'm quite sure these are all live links on these slides, and I hope that they can be provided. But there are ways to identify free and low-cost internet and devices, and I've put some of the links there. This is a great way to deploy. We've worked closely with volunteer organizations in our community. It was actually much easier when we had the library. That was a wonderful, the public libraries are a wonderful partner for information access and literacy. But you can also include volunteers like medical students, clinical research coordinators who are not doing patient-facing research, if you're at an academic institution, are another option, and community members who are wanting to participate in community support during the pandemic are all people that can be called on to help patients set up video visits. There are also national organizations. NDIA stands for the National Digital Inclusion Alliance, and there are wonderful people who are dedicated to getting people access to the internet in order to better their lives. So we do think, and we know that, when I do primary care and I do telehealth visits, the idea of trying to be a person who in that moment is also trying to support patients' digital access is pretty tough. And so I'm not suggesting that this is part of a clinician's everyday workflow, but I do think that we should think creatively about our community resources to try to think about who can help us with this goal of getting to our patients when it's not so safe for them to come and see us. Okay, I will keep moving along. I'm not able to see the chat, unfortunately, so hopefully Stacy will interrupt me if there's something there that, that I should respond to.
We're going to do Q&A after, if that's okay.
Absolutely. Okay.
Perfect.
All right, so then I'm going to present this in the way that many clinicians think about it, which is before the visit, during the visit, and after the visit. So this is a sample clinic workflow from before the visit. And this is not, as you can see, this is not simple, right? So let's just acknowledge that we're going to need to invest some time to get new workflows down, as we all had to do when we first implemented electronic health records. It's a lift. So it starts with patient being scheduled for a telephone appointment, and then the even step of the patient understanding that that's an appointment, right? Sometimes when I call patients, especially if it's telephone only, they think I'm just calling for a chat. They don't understand that this is like actually their visit. So that's an important step. There are some scripts that we have developed, which we'd love to share, that would be that hopefully will be helpful to have guide a clinic staff member in what they should say in that outreach that says, you have a telephone or video appointment. Are you available at that time? And then offer the option of a video visit. And then if they're interested in a video visit, the workflow then is to help the patient download whatever platform you're using. Zoom is just a placeholder, obviously. And then to try it to make sure they're able to use it. And then if they're not interested in a video visit, then you would offer them telephone only. This is also an important time to get people onto the patient portal. So we have such a low % of people on the portal, but now is a time when it's even more crucial to get them there. And so a time when you're calling them about a visit is an ideal time to say, hey, you know, everything that we would normally give to you in the visit is available for you on the portal. So please, please do that. The other thing that I think is really important is that I don't know how other people have been handling this, but I haven't talked to clinicians yet whose clinics templates or schedules have been at all adjusted for telephone visits, and I'm going to put that in as a recommendation as something that should happen, because there needs to be time built in for connecting the call. The other thing that we can potentially call on in this time is many of us who have comprehensive electronic health records have some kind of reminder capability that may or may not be something that has been turned on locally. So that's another recommendation. If there is some sort of an automated reminder capability, either through the patient portal or through one-way texting, which is something that some EHRs can support, it's particularly important for these type of visits. And then I want to mention that one free tool that a lot of physicians are using, and I don't have any paid relationship with them, but I think this has been a time when we've really recognized the value of Doximity Dialer and their no reply texting. So Doximity Dialer allows you to have caller ID representing your clinic phone number. And so it sort of masks the call, so you can make a call from your cell phone and won't show up as an unknown caller or as your personal number. It will show up as your clinic phone number. So if your patient ever tries to call you back, they will call the clinic back, which gives me some peace of mind, because then I know if they need something, they're getting someone. In terms of, and the other thing that we have been using at our clinic for reminders, because we don't have reminder capability in our electronic health record at this moment, is there no reply texting. So you can send patients a text and there's no capacity for them to reply back, which is good, because it is it's often patients who violate HIPAA on text chains, which is why we try not to text them. So those are just a couple of concrete tools. Okay, I'm going to keep moving here. During the visit, and these are some of the suggestions from expert clinicians where I work. So I don't know how many on this call are clinicians who've done telehealth or video visits. I have found that they do tend to spiral pretty rapidly into sort of a very broad download. And so I think structuring calls and even telling patients at the beginning, we have X number of minutes. I really want to make sure that I talk to you about X, Y, Z, sort of the things, the more concrete communication skills that we have found that we need in all remote settings are particularly important. Language interpretation can be really challenging, and it can be technically challenging and logistically challenging. So I think this is the time to try to see if it's possible to have interpreters, a team-based workflow that can pull in interpreters in a timely fashion. I think also if you are thinking about language interpretation, you can consider how to engage family members, particularly at a time of a visit reminder call in advance, and make that a team-based activity. And one more word about interpretation. So I know of and have no relationship with or financial interest in a platform called Voice, which is spelled V-O-Y-C-E, that has fairly seamless tablet-based three-way calls for interpretation. So if that's of interest, that might be a platform to look into. It's quite reasonable. It's much less of a financial it's much less of a financial commitment than typical telephone interpretation services. And then I have resorted to using an alarm on my patient phone calls. And I think it's, people are in a different mental space when they're in a visit with you and they have all these cues to keep moving along, right? But when people are in their own space at home and having a conversation, I have found that it is harder to circumscribe that to the number of minutes that we have. So that's another very low tech solution to keep it moving. And we have, well, let me walk through this clinic workflow, and then we have a number of resources on our website about how to make this work. So there is also the step of, if you haven't been able to establish if a patient has an interest in video, can still bring them in at the time of the visit and start the visit by telephone, and then help them get on to Zoom. And I have done that a couple of times, and it is possible. So after the visit, I think it is more important in the world of remote visits to put important follow-up into plain language and put it into the after visit summary, right? Two of our UCSF colleagues who work with us in the Center for Vulnerable Populations, Dr. Kung and Dr. Fernandez and colleagues, did a study where they looked at the accuracy of Google Translate for physicians, custom generated notes in the after visit summary. And what I mean is, after a visit, what I might put in the after visit summary is, don't forget to get your blood drawn between this and this date so that I can see if your new medicine is working okay. Right? So those sorts of custom sentences written by me at the end of a visit, putting those into Google Translate, they actually found that the accuracy was quite good. So if you have somebody who you're doing a video visit with a family member, but you're a little bit worried about whether or not the follow-up is going to happen, it's okay to put some English instructions and then use Google Translate and paste in what you get, and feel comfortable that there was nothing in that study, there was no harm associated with it, and they were by and large quite accurate. So I think more communication is better in this era. And then if there's the possibility of follow-up calls, those are always worth using judiciously, especially where you feel like there's a follow-up step that may or may not happen. So I am going to keep moving here. So we are worried, as I know all of you are, that telehealth has the potential to exacerbate existing healthcare disparities given the underlying digital divide. On the other hand, the reason that Dr. Lyles and I were so passionate about telehealth before this happened is because we felt it was particularly important for our diverse patients, many of whom have to take half a day away from work and will not get paid if they don't come in to the physician, and have to take 3 buses and incur significant costs to make that visit. So telehealth has the potential to improve equity or exacerbate disparities. And the way that that is going to play out is all based on how it's implemented. So it's in our hands. Multiple strategies can mitigate those differences, especially with consideration of every step in that patient's journey. And this is where Dr. Lyles alluded to the importance of looking at who's taken up the patient portal and how it's been taken up. And I want to really, if there's one thing that one word that I hope that our presentation encapsulates for all of you, it's training, right? So digital inclusion involves training and technical assistance. There is, as Chelsea said, we can't solve all the access problems in the world, but access is also necessary but not sufficient. So there are things we can do to facilitate our patients' access to the devices and services they need for digital inclusion, but we need training, 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 and training to get them there. And I do think that partnerships, the second most important word for this talk would be partnerships. So we have a few recommendations. I think the messaging for patients has to be around maintaining in-person relationships, since we don't know when we're going to see people in person again, and eliciting specific barriers and perceptions. On the provider and system level, screening for devices, access, literacy, providing technical support, and developing standardized workflows and scripts and whatever we can do to make it easier for people. Training also applies very much to staff. We have, tech facility is not a hiring criteria for our medical assistants, and they are really drawn from the same communities that our patients come from. That's very intentional, and they're drawn for their language skills and their commitment to health equity. But they may also need some training around becoming the tech support person. And then we need to support clinicians to do this. One of the things that I'm hearing from my colleagues and that I feel myself is that I really miss being in the same room with my patients, and I miss hugging them, right? And that was a lot of my job satisfaction. So it's important to acknowledge that this transition, telehealth may bring some increased patient satisfaction. It's not clear how it's going to affect physician satisfaction. And then at the community policy level, I think there are more partners than you think around digital inclusion, and look around and try to connect. And then, of course, we hope that there's advocacy around broadband as a utility or a fundamental service. I hope these resources will be of some concrete benefit to you. They're all designed to be things that you can start using today. We have some telehealth resources, including tips for caring for limited English proficiency patients. And then there are some digital equity resources for access on this page as well. So I think now we move to the discussion part of the panel, and thank you for your time and for listening.
Thank you, Dr. Lyles, Dr. Sarkar, and Chelsea for joining us today and those presentations. We'll open it up to questions, and Bernadette is going to take the lead on reading some of those off for us so I can continue sharing my screen.
Sure. So the first question we have is, how long will COVID telemedicine be in effect? And I think what they're referring to here is around the waivers. So Stacey or Shannon or Bisan, folks, if you have any thoughts.
Yeah, I'm happy to layer into that. I think the short answer is we really don't know. The public health emergency has been extended at least for another 90 days, and I think that was effective late July, so recently. So I would anticipate that that would continue until at least then. But just given what we've all been kind of seeing in the news about continued surges and cases continuing to climb, I don't know that I foresee major changes happening anytime in the near future for telehealth. And there's a lot of work being done to also support making these changes permanent. So happy to share some of our AMA advocacy recommendations for the continued coverage, and happy for anyone else from the states to weigh in as well.
This is Shannon. I'll just say that there are a lot of variances too by payer and even the state Medicaid programs, but they continue to be extended. And as Stacy said, I don't see that ending anytime soon because of the surges, but we are all keeping a close eye on this and pushing for the permanent solution.
Great. This next question is around platforms. So the question is there a platform that is really rising to the top, Doxy versus Zoom, et cetera? And maybe, I don't know, Dr. Sakar or Dr. Lyles, maybe from your experience, do you have any thoughts?
Well, I will say that the short answer is no. I haven't seen one platform that has risen to the top that is going to be the new universal standard. I do think that we are hearing more and more people talking about doing it through the patient portal and the electronic health record. So I think to the extent that something will become the standard, it's going to be what does your electronic health record and your patient portal support? Courtney, I don't know if you have.
Yeah, I agree with that. I was nodding my head. I agree with that. That's the most often that I've heard. So whatever, if you have Epic, if Epic only supports one platform that's integrated, I think that has a lot of advantages from a streamlined standpoint, right? And it is, but I think the idea that some people are not on the patient portal, like I alluded to before, creates another scenario of passwords and all the other things that we set up for patient portal, whereas Zoom or another platform has some potentially lower bars for people to get in. So I think there's some things to weigh there, but I think more likely than not, we will go to more of an integrated way to deliver telehealth, most likely.
And I think, I hope that we continue to have the non-enforcement of the, privacy and security restrictions around things like FaceTime, because honestly, if somebody's granddaughter has an iPhone and can FaceTime me so I can see a patient's rash, like pragmatically, that's what I want to do as a doctor. But I don't know that that's going to be something that we can hope will continue to be reimbursed as a video visit.
Great. This next question is around scheduling. So the question is, has anyone had experience with modifying schedules to accommodate telehealth visits? If you could share a little bit about that. And maybe Dr. Sakar or Lyle.
Yeah, I mean, I just have the experience of sort of socially hearing there is a health system in our area that has started giving 5 minutes for the medical assistant to call and hook up and get the person into the video visit space, and then the provider joins. So so the patient time has decreased a little bit because the first few minutes are them getting into the visit. And the physicians who I've talked to about this, they're not really, what they're experiencing it as is they're really not super able to document, right? So they're having they're having almost continuous face time because the medical assistants are doing this. But if you look on a piece of paper, you'll see little breaks for setup time between visits. But I will tell you candidly that most physicians are experiencing this as a longer workday. And part of that is because no-show rates are generally lower. People will generally answer the phone. And so many many of us are scheduled with an expected no-show rate that is now not happening. So that's my experience with scheduling so far.
Dr. Sarkar, this is Stacy. Interested in your thoughts on kind of a mixed schedule between in-person and virtual visits versus kind of blocks of the same kinds of visits. Have you seen or heard of a preference there?
Yeah, I think people physicians find it hard to go back and forth, but I think patients prefer to have the choice. And so we have to decide what we think is practical in the long term. But that's my purely anecdotal observation, is that, you know, it's easier to get in the mindset of, I'm going to see people, I'm going to mask up and do my thing, or I'm going to sit here in front of my computer and with a huge bottle of water, because I'm not going to step away from it for, you know, the next 4 hours or whatever. I'd be interested to hear what people on the phone think about that. But from what I can tell, physicians prefer to do one or the other.
Yeah, and that's an interesting dynamic, and I really hadn't thought about it in the context that we're living in now, in terms of having to kind of completely suit up, which is not what wouldn't be the normal in another environment when we weren't in a COVID world. So that adds another layer of complexity to go back and forth, for sure.
We're getting some comments in the chat as well of others agreeing with that too, being their experience. So just wanted to share that. This next question is around training. So the question is, are there any grants for training or helping patients get access to telehealth, or NIH grants to study telehealth in poor communities? So a couple of things in that question there.
Yeah, maybe I'll jump in first on that one. There have been some programs out there you might have heard of, but training is a little bit hard, I'll be honest. I would say there's more information out there. For example, the FCC, the Federal Communication Commission, put out a large amount of money, $200 million, to help with devices, and specifically for telemedicine. I'm guessing many of you saw that, especially for safety net or lower income or rural providers. But the training part is more challenging, right? Because even if you get the devices, how do you ensure that the patient knows where to get the low income plan, or how to use it, and those kinds of things? And that, I have found, has actually been some of the Achilles heel in some of the other things that we've been doing. It's sometimes people focus a little bit too much potentially on the devices, in my opinion, or just the internet access, and not enough on the training piece. And so would love more of us jointly talking about training, because just because you have the devices in either the clinic setting or the patient setting, it doesn't mean that there's the transition. NIH has put out a lot of grants about telehealth and COVID in particular. Again, my experience running a lot of NIH grants, it's a little harder to get training into the grant rather than impact of telehealth. And to me, impact of telehealth is going to be really dependent upon how comfortable people feel in using it. And so, I mean, maybe I'm biased, but of course I'm running grants that have training in them, but I think there could be a lot more in that space in particular. Of those three pillars that I mentioned, devices, the high-speed internet, and training, I would say training is probably the most overlooked.
Great. Dr. Libby, did you want to make any comments? I see you've made several in the chat here. Did you want to verbalize it via voice?
Sure, I can do that. You know, it's one of the things that irks me a little bit, because you hear this, is that telemedicine can exacerbate health disparities. And to me, it's one of those things that if you can see 5 more people who would not have been seen, you're actually reducing those health disparities. And it's using negative terms that really undermines the success of telemedicine to evolve. The innovation takes place in response to the need. And there's definitely a need, and there are ways to innovate the way you deliver care. And to me, it's not having a clinic where you have to bus someone and then have them wait in the waiting room and then come in and see someone in a room. You can really do a lot of it this way. And it may be, yes, taking the phone or taking a tablet, to a location that is close to a neighborhood where there is a lot of health disparity and difficulty for people getting access to care. So, I mean, there are ways for us to do that. And so that's my comment about that health disparities issue relative to the reputation it gets, because there are a lot of people out there who are looking for reasons to say, no, we shouldn't pay for this, we shouldn't do this, we shouldn't incorporate it into our practice routines. And I think we have to give it a positive spin if we can. I can also say something about scheduling. I know that my experience, and I've been doing it for a number of years in my office, but over, of course, the last 4 months, it's become my only vehicle by which I see patients. We have in my practice, and I'm a primary care pediatric practice, but we start at 8 in the morning, we go till 8 at night, and people will alternate the hours that they spend, but they can choose where they want to deliver the care, whether it's at their home, in their office, or in a little computer room in the clinic. But it really is one of those things where it's a dedicated time. We don't interrupt people and switch them in and out of their office, their face-to-face in the office visits versus getting them online. But this is something that you have to work out yourself. What I find, though, is that if you are in a comfortable place and you have access, when you're doing a telemedicine visit, you have an incredible opportunity to have a screen that you're looking at. You're engaging with the patient, but at the same time, you can be looking at things in their medical record. You can be researching issues that they bring up. You can look up medicines. You can do all kinds of things that you can't necessarily easily do without being totally distracted from your patient encounter. When you're in a room, even holding a laptop or whatever, it's a remarkable vehicle by which you can deliver care, and one that definitely is integrated into the way you practice and how you set up your clinic. It's very well received, and yeah, there are some who can't quite figure it out, and we need to be able to do that for them.
Yeah, I think we're totally on the same page. I mean, at least from, hopefully we didn't present it too negatively. I think we totally agree that the potential is really strong. I think the only thing that worries me about telemedicine for equity is if we put out there that we offered it and then patients didn't take it up and use it. I'm worried that people will say patients didn't want it or they didn't use it. And so how do we talk about that need, the need for the training and the need for the extra support, and get the reimbursement and the policy to align with truly, like you're saying, truly helping people do it, rather than offering it in a way in which just the most well-resourced individuals would take it up to begin with. So I think we're on the same exact page about that. It has a real potential, and I think it's more about framing it for others so that they can make sure the investment is balanced. Yeah, maybe I'll stop there. I know we're almost at time, so I think we're almost over.
Thank you, Courtney. Yeah, we are gonna wrap up. Thank you so much, Chelsea, Dr. Sarkar, Dr. Lyles. It was great to have you. This was super informative and helpful, and I think everyone can appreciate to not hear my voice and the same others that we've had on previous webinars. So this was really excellent. Thank you so much. If there are questions in the chat that were unanswered, we'll go ahead and pull those and get those answered and send those out to the group here after in the next few days. And then just kind of one thing to close on is the CME link. We'll send this out as well. It can be found here and claimed for the event this evening. And I think that will wrap us up for the night.
Bye.
Whoop.
Thank you.
Thanks, everybody.
Thanks, everyone.
Thank you.
Thanks, everyone. We'll talk soon.
Thanks, guys.
Bye.
We'll talk in 2 weeks.
Have a good night, everyone.